height আর weight আছে স্যার
height and weight ঠিক আছে suppose your boy case is boys, they take the boys, so all of you it is better bring the these two one. Suppose your case is girl, you take the girl. So you have to do the age, you just plus. In the case of weight and height, I will tell you how to take the weight in centimeter. I just arrange personally for you. You have take it like this way, you know. But the method is there. Have any of the got you the Physics Gupta book?
we have got it.
All yes. So in that particular page, general survey and just basic clinical, if time permits, the systemic also. So just what are the method you know? Measure it, measure the length, height. In the case of infant, I will tell you how to take the length of the infant. Then you plot it. Weight is available by the weight method. You just plot it, and it will tell you good impression to the examiner. Among the 7 examiners, 4 examiners come from the outside. So there is a good impression. So I want that every student to write the framework properly with good handwriting with this good impression out of the tiles. So that will be very helpful for passing the long pages. So it is probably all if you know, one is length in height, that is age and the method. All you know these things, you plot it. If any of you have any confusion?
Yes sir.
Definitely. Weight machine will be there, and we'll try to arrange 4 or 5 blood pressure instruments of different class. And this infantometer will be available there also. Height is problematic. If available, then you give the steady meter. If not available, further one. Ideally, there may be height. There should be upper segment lower segment ratio. There may be arm span. Given in the book how to take the lower segment. By the sitting position, you take the upper one and then deduct from the total. Arm span is that when you start take a long case, false case, facing the Marfan syndrome, that in the cases we take the arm span actually. Arm span just tell the child to take that wall actually like this way. You make a point, like this way. You make a point and take the arm span, take the height. It is mainly applicable by the long stretchers. Long stretchers commonly classically it is the Marfan syndrome, but for the undergraduate we do not do that. At least you should know if there is a case of short stretcher like Down syndrome, hypothyroidism, any type of other short stretcher, familiar short stretcher. Then you should know how to take the whether is it proportional or disproportional. Means you take the total and you know the upper segment and lower segment. Normally at birth 1.7:1. And we come at 3 years of age, almost 1.3:1. At 7 to 10 years, it becomes 1:2, like this way. So you know these things. If it is proportionate one, we call proportionate short stretcher. Disproportionate short stretcher. Mean according to the rule, it does not follow the rule. Means disproportionate. At least what are the cause of disproportionate short stretcher? Can anybody tell me? Disproportionate means upper segment, lower segment, that is a particular rule is there at birth 1.7. So tank could be 1.7. Suppose 17 centimeter, the lower segment will be 1. At 3 years age, it will be 13. That's not 1.3:1 means like this way. This is the normal rules, but any those conditions who does not follow these things like achondroplasia is the joker who perform in the circus actually. See, that limbs are short. The limbs are short. Trunk is okay. So that is a disproportionate shortage because they have a rhizomeric shortening. Among the shortening, the forearm, femur is more short. So that is a disproportionate shortage. A case of familial shortage, long maximum cases, the skeletal dysplasia, majority of the cases may be disproportionate, or others usually proportionate shortage. So all of you just convey this message. All of you need not to be colored. It in black and white is available. Make it print, make it ready before exam. You just attach at the end of that. Before share come, I am just starting the X-ray.
So if the child is more than 5 years of age, then we'll just measure the BMI.
Not compulsory. If you think it is necessary, if it is, you can measure it, but not compulsory. First of all, I'll see just how to read this normal exercise. Although this exercise have some problem, how to read a normal exercise. before any comment to an X-ray, we should make some prerequisites. The other is X-ray of the chest or X-ray of the abdomen or X-ray of the stomach. A classical chest X-ray should include lower one-third of the neck, upper one-third of the abdomen. Many of the cases you get the X-ray done by the technician, the whole the abdomen also takes. This should not be. This is the ideal is that lower one-third of the neck, upper one-third of the this should comprise the chest X-ray. Second is the position of the patient. Because if the patient is some deviation from midline, then we should lot of changes occur, and that make a lot of confusion while you interpret the X-ray. So how we can see the position of the X-ray? Position should be on the midline. This is the clavicle. The medial line of the clavicle, this should be equidistant. From the if you take a midline, this distance should be equidistant. Suppose if the patient is like this way, everything changes. Many of the time, what happens? The child is fighting while doing the X-ray. 3 or 4 year child, as the child is unknown previous, everything, as you know, the child is fighting. So many of the times it becomes not possible to perform the X-ray. Third is the exposure, means exposure of the amount of the beam passing through this. If the beam passes through and through, that becomes black. If does not passes, that becomes opaque at the wide. This is the normal rule of X-ray. So a adult person have a thick chest wall, it is fat is there is thick bulky muscle bulk is there. So the same radiation cannot happen in the case of small kids. So sometimes there is some problem by the technicians to give a more exposure. If there is more exposure, what happens? If there is an opacity or lung pneumonia, that also get vanished actually. How we can say that exposure is okay? Normally rough parameter is there. This is the vertebral column, cervical, this is the thoracic vertebra. Now heart actually is a muscular chamber, and it is not a thin balloon-like structure. It is thick muscular structure, and it contains blood inside it. So usually heart is radio opaque, and behind the heart, this vertebral column, the lower thoracic vertebral column, should not be visible. Normally should not be visible. Suppose you see there is visible, should not be visible. So you give a rough estimation, that's exposure, how much exposure have been given. Then you have to assess right and left. Which one is right, what is left? Before commenting, at least assess these things. How we can assess left and right? First is the mark done by the technician. L. Yeah, if L is given, or everybody is noted. L noted by the technician is. So L or R. What are the other point? Other point is the right dome of the diaphragm. Usually, you have to consideration of all the features. Higher than the left one. Here is both are equal. Normally, the apex of the heart is on the left side. Maybe dextrocardia, but this is the actually fundic gas shadow, and upper portion actually the colonic gas shadow. Actually, fundic gas shadow look like this way. Fundic gas shadow look like horizontal and with a semicircular. Fundic gas shadow is on the left side. So all together we consider that left. Sometimes the technician may make any defect. Suppose like this. So make a confusion that it is dextrocardia or not. So making it dextrocardia or normal, you try to match all the findings. What are the findings I told? That this is the indicator. Number 2, dome of the diaphragm. Number 2, the dome of the diaphragm, apical ridge and the fundic gas. All together you just consider. Then we will start from the outside to inward. What are the structure? Outside there is skin and subcutaneous tissue. Then come the bone, then come the lung, and then the heart actually. So although we will not give you, but in the subcutaneous plane, is a good assessment. The nutritional level of the patient can be assessed. But on practical clinical ground, surgical emphysema we have seen. Many of the cases surgical emphysema, there is a slit of ear actually, surgical emphysema. Similarly, if there is subcutaneous calcification, it can be filled up. Sometimes there may be a chesty drain, like stones. Then come the deep. Then come the bony part. In the bony part, actually, this is the clavicle and this is the reticulation. The first we count, start from here. This is costal cartilage. Second, third, fourth, fifth, sixth, seventh. normal lung usually expand up to 7, not more than that. If it is more than that, it is considered hyper expansion. Then we come to the lung profile actually. So before any interpretation, we should do far requisite whether the X-ray is appropriate for the ask for. Suppose a chest X-ray should lower one third of the neck, upper one third of the abdomen. Then you see which portion is right, which portion is left. Then you see the exposure of the patient, and then you see whether position of the patient is proper or not. Other point, whether the X-ray is in full inspiration or in expiration. Ideally, we take a deep long breath, hold it, and the next should be done. In the case of when we ask for the lung pathology. Why? Because if we make a long breath, lung is will be expanded, so any pathology can be picked up. What happens in the case of expiration? If I do expiration, lung volume decreases, all the bronchoalveolar margin come together, making a fall impression that pathology. So ideally it should be full inspiration, but in the case of small kids, it is not possible. They cannot hold it. So at that time, that's some problem. But in the exam, we will not give like that. So then you interpret the bony changes, clavicles, ribs, sternal bone. Sternal bone can some half of the patient. Clavicles, ribs. Sometimes, although not given in the undergraduate, but that lot of changes can happen in the ribs. Ribs will be fractured. The rib will be horizontal. Ribs will be like this and oblique, but it may be horizontal. Sometimes like mucopolysaccharides, ribs may be O-shaped ribs. So many changes can happen actually. But never forget here, any surgical effusion present as a subcutaneous pain, any obvious rib changes. Suppose there is a fracture, obvious, very obvious. If given in the exam for the undergraduate, that should be very obvious for you. But never forget to see. So come from the outside, subcutaneous pain, then the rib, then the lung profile, and then the heart profile. Lung profile and the heart. So in the lung, you can see some pathologies there, and then you see the heart, cardiac heart. Heart first you look for the whether the cardiac silhouette. Silhouette means what are the shape. Everything have a particular shape. Our man have like a particular shape. Dog is a particular shape. So this is the normal shape of the heart. We call in medical term the cardiac silhouette. So this is like this way. And this cardiac border is formed, although it is not prominent here. It is the right border of the heart, this is the left border of the heart, this is the apex of the heart, and this is the lower portion, base of the heart. Not base, like the lower portion of the heart. And this is the base of the heart actually. The right border of the heart actually mainly formed by the right atrium. Left border of the heart is mainly almost 80 to 90% formed by the left ventricles, and some portion this is auricle or left atrium, then the pulmonary bay, and sometimes the heart of the outer actually, lower portions. And this right ventricle actually it does not form any border of the heart. What are the importance? So while seeing the X-ray, you see that whether the cardiac silhouette is normal, cardiac silhouette is large, whether border have been obviated. Sometimes it also happen due to some opacity of the lung, right border of the heart cannot be seen clearly. That indicate right middle lobe pneumonia or upper lobe of the apical portion of the lower lobe. If there is an opacity obscuring the right border of the heart is not clear, that indicate two things, either the middle lobe pneumonia or apical portion of the lower lobe pneumonia. That position is such that on the surrounding the right heart border, so that will obscure, not clear cut. And then you see whether the heart is normal shape or heart is enlarged. Now enlargement of the cardiac shadow can happen in two conditions. One condition when the heart itself is enlarged, like cardiomyopathy, maybe multivalvular heart is leading to large heart. Sometimes heart cardiac shape may be enlarged due to some collection of the fluid outside the heart. That is known as the pericardial effusion. So how to assess the two portion? Give two pain. Commonly asked in the exam, two pains. Commonly asked in the exam whether the heart shape is okay. And you see normally the heart, 1/3 of the heart is, if we make a midline, maximum 1/3 of the heart on the right side of the midline. If you make a midline, 1/3 of the heart, maximum 1/3 of the heart, if you take it to maximum whole cardiac size, then 1/3 maximum may be on the right side, rest to be on the left side. And then how you know the cardiothoracic ratio, what you heard it, CT ratio means cardiothoracic ratio is a point charts for assessment of the cardiac enlargement or not. That is cardiothoracic ratio. All of you have to demonstrate in the exam, and the examiner will ask you, show me the cardiothoracic ratio. Cardiothoracic ratio means maximum internal diameter of the chest at the diaphragmatic upper border and the maximum of the cardio, heart, thoracic total. In the case of pediatric age group, it is 0.55 RPM. So cardiac means total. Suppose, for example, it is 10 centimeters. Suppose heart is 5.5 centimeter. So up to this level is normal. Suppose it is 6 centimeter. It is 10 centimeter. So it is cardiac. Second question that I asked, how to see the cardiac maximum border. So this is probably all of you know, but I am telling you. You make it mid horizontal vertical lines. From the vertical line, the maximum distance from the midline in the right border. Suppose this level. Suppose, for example, this level. Okay. You draw another line from the apex. This both lines should not be the same level because apex is here. So in this border, left side, it will be here. I want to tell is that from the vertical line, maximum distance of the right heart border and maximum distance of the left heart border, because both will not be in the same level. I want to say that both will not be in the same level. So maximum, suppose here level is maximum, but here level is minimum. So from the vertical line, you have to add this one plus this one, maximum. You add. Suppose it is 3 centimeter, this is 4 centimeter. This should be very clear. Cardiac thoracic ratio. Then coming to the lung. You know the normal lung is black in color in the presence of the ear because it should be passing through and through. You should know, and it should consist of bronchodilatory marking should be there. If lungs to be seems to be black but having no bronchodilatory marking, then you think it is hyper more of ear, or it is no, not lung actually, means pneumo actually. Pneumo means ear in the pleural space. So first you look the whether lung is okay or not, compared to the opposite side, whether the bronchodilatory marking present or not, and this is the costophrenic angle. Costo means costal cartilage, phrenic means diaphragm. The costophrenic angle between the heart and these things, cardio, heart and phrenic, cardiophrenic angle. This is left-sided costal cartilage and the diaphragm means phrenic, left costophrenic angle, and this is the cardiophrenic angle. This angle should be clear. And normally in the pleural space, suppose in the case of adult, possibly 75 to 150 ml of fluid may be present, but that does not come into the X-ray. Then you see the bronchodilatory marking is present up to the periphery or not. Bronchodilatory marking usually visible on the X-ray if we divide into 3 parts: medial 1/3, middle 1/3, and lateral 1/3. The lung. Then normally bronchodilatory marking should be visible as to middle part, means lateral 1/3 of the lung. Normal bronchodilatory marking will be faint and may not be visible. That is normal. But if in the lateral third, again it should be clear that if we divide into medial third, middle third, and lateral third of the lung, then this bronchodilatory marking normally in the lateral 1/3 should be minimally visible, difficult to visible. But suppose that is more visible, means
Pneumonia consolidation.
Plethora.
plethora. So term is used, this bronchodilatory marking more prominent. So when it is visible in the lateral third also, it is plethora. Similarly, oligemic means it is mainly visible in the medial part. The middle part also not well visible. Then is oligemic lung. What is the condition of oligemic? Less blood flow. Classical example is pulmonary stenosis. Condition of oligemic lung. This way we can see whether it is plethoric lung field or oligemic. Then you see any pathology over the whole lung. Whether the lung volume of the right and left have been changes. Inside the lung any opacity. Outside the lung something any mass which composite, like this way you have to proceed to. If it is an opacity, does its opacity is patchy or opacity is particular low, along to the constellation in the particular lobe, the lobar pneumonia. And whether there are any changes of the mediastinum. Mediastinum indicate upper mediastinum by the trachea, lower mediastinum by the apex. This is the clinical as well as procedure. Started depending on the active busy. Right and left. You have to know which one is right and left first. Right, left. Okay. So on the right, what we have seen, first, see that is a bending of the vertebra. The position of the not normal. But this, as this patient have a gross obvious feature, so it may be given. This type of X-ray may be given in the exam. Like whatever pathology you are seeing, left lung is okay. You should look the trachea also, but and there is some homogeneous opacity of the lung pit. Homogeneous. এই ছবি টবি করিস না দরকার নেই এই এক্সে থাকবে এক্সামের জন্য আলাদা এক্সে রাখা আছে দিস ইজ অ্যান প্রোটোটাইপ কিছু কঠিন থাকবে না সেম প্রোটোটাইপ থাকবে অ্যাট লিস্ট ইউ হ্যাভ টু ডিফারেন্সিয়েট এটা কি এই এক্সে কিন্তু থাকবে না পরীক্ষার জন্য আলাদা এক্সে রাখা আছে হ্যাঁ this is just of the it should be ideally upper one of the more of the hotter name as you see there is a homogeneous opacity with a crescentic border in the right side and all this type of opacity there are two causes actually lobar pneumonia hole or maybe correction of the fluid that is blood that is the two conditions nothing else if it is pneumonia means there is some continuation means the lung volume does not change the air depends on the alveolar which is converted into X-ray. So there should be no change of the lung volume. And if it is consideration, always look whether any bronchovascular marking present or not. Because in the case of lung, if you see the structure of the lung, there is some conducting zone is there. In the later part, there is some transparent zone. But conducting zone, which airway may be visible, we call it broncho. Means the larger airway is visible because the airway is tube. Okay, it contains air, but normally surrounding that alveolus, so it is normally not visible. But when the alveolus gets opaque, only airway containing air is only the airway inside the air is not collapsed actually, it is patent, but surrounding all that collapse means opaque, it is visible, known as the air bronchogram. So first, if it is homogeneous opacity, look any air bronchogram present or not. Means black present or not. Black is nothing but the conducting zone. Have you understand that if you see the lung structure, there are 17 or 19 division between initial portion conducting zone, another is for the oxygen exchange occur. So initially conducting zone, when there is pneumonia, there is some that becomes opaque. But the air tube not get pull up, so it's patent. And as inside the tube is air, so it is black and shining. So we cast a blackish shadow known as the air bronchogram. And remember, when there is pneumonia, there are only changes of the mediastinum. Mediastinum only changes. Why it changes? The same position. Only the air is replaced by the X-ray. So look these things. Whether it contains air bronchogram and whether there is some changes of the mediastinum. Upper mediastinum by the trachea, lower mediastinum by the apex. Whether the apex is shifted or not, or air bronchogram. Here, it seems, in our eye, it seems to be mildly shifted. Heart apex should not be so much of distance. Shifted, but as the position of the patient is like this, we cannot make any comment of the trachea. No, we never make any comment. Sir, the position of the trachea is bended, so it's difficult to interpret whether the trachea is shifted. Normally, if there is collection of the fluid in the pleural, that should be shifted. If it's mild collection, that will shift the lower portion, lower mediastinum by the more and more. Both trachea, both will be shifted. So whether the lower mediastinum or upper mediastinum shifted, that will depend how much amount of the fluid will collect. And as the collection of the fluid is outside the lung, so always given compression effect. Sometimes in the case of pleural effusion also, you may get some collapsed lung bladder. Means there is a light lung, collection of the fluid is compression, collapsed lung bladder can also be visible. Kyphosis cholesis X-ray, actually this is AP view or lateral view will be given. Normally you will not give it. Okay? And he is telling that there is some bending, is it some cholesis or not? So this is an homogeneous opacity without any bronchoalveolar marking, and there is some shifting of the lower mediastinum. Apex will seem to be shifted from this side with a crescentic upper border. It presents the good points, 3 points. Homogeneous opacity without any bronchoalveolar marking, shifting of the mediastinum on the opposite side, and upper border is crescentic, indicating right side of the pleural effusion model. Then the examiner will do why it is not a case of pneumonia. What will be the clinical finding of this patient when they present? How you treat the patient? These are three questions. What is the diagnosis? What may be the clinical picture of the, what will be the clinical picture? The patient will present with the history of fever, cough, and will be present with respiratory distress. On examination, patient will be tachypneic. If you examine the patient, there will be sitting on the mediastinum arm. On auscultation, there will be decreased bass sound. Like this, all these same things. If it is pneumonia, that will what will happen? Initial presentation both are same, both are tachypneic, there is respiratory distress. আচ্ছা তুমি এক কাজ করো, তুমি আরেকটু পড়ি তাহলে। There may be, if it is case of pneumonia, suppose it is glycated molecular equation, but suppose your case is pneumonia, then what will the clinical presentation? This is the background history. On examination, patient may be tachypneic, maybe interstitial suction, depending on the conditions, patient may be shy, or whatever may be this or this. On auscultation, what will find you get? If you just state here, what finding you get?
Diminished
Decreased sound. This is the most important. On the case of if it is lower pneumonia, suppose this is pneumonia, what finding you get? This is also decreased breath sound, but we may expect sound. If the bronchus is patent, bronchial pressure will be there. We may also expect some crepitation. But here we do not expect anything. So your task is that from the you should be very clear the how to differentiate clinically and radiologically pneumonia with equation. This is a task and will be a very common important task and question you ask. Both in clinically and radiologically. This is your task. And remember, within next 1 month, if you have any confusion, something else, you come between 12 to 1. Not only myself, but a lot of patients there. They will free all the time. We will see. If any confusion, will definitely help you to clear. Your task is first task is this today task. Remember these things. This is a check stay PA view. Commonly PA view is taken for this is the convention PA view. Showing no obvious here. Whether the patient is the midline, yes, midline. Cardiac salute is also okay. Then you see the angle is also not obstructive. However, there is some patchy opacity, both lungs. It is your description. Like then examiner do what may be the cause, what are the patchy opacity, what are the miliary opacity of the lung. This is 2 to 3 causes. They're giving in the book. I'm not going to detail. It will take a lot of time. So you read it from the book. So what will be my focus? I told previously the ideal testing should upper one of the abdomen, lower one of the chest, you take more of that. But you do not think of this. You see first whether the position of the patient is okay, right and left is okay. First you see exposure, you forget. But then you see the any obvious bony changes, any subcutaneous, any obvious changes. Then come to the lung part. Then come to the cardiac salute, means cardiac shape is okay. Then you see the angle is okay. Then you go to the actual view. There is some opacity bilateral lung. Then you give some. This is the X of the chest showing some bilateral opacity of the lung. Both the bronchus angle is clear. Cardiac shape is normal. What's your diagnosis? How you confirm? What are the findings do you expect? How you treat like this? This will go to this. Today I am not going details of that. The diagnosis. Diagnosis. You read from the book. Book are giving everything. Miliary opacity, patchy opacity, given in the book. You read in every book. You read it from the book. What are the causes of miliary opacity? 1, 2, 3, 4. Only also remember 1, 2, 3, 4. Like given in the book. That is easy. Suppose this is again. Okay. So here there is some kinking of the trachea. But we do not ask you anything from that. That is actually the position of the patient. Because you see the age of the patient from this maybe 1 year, 2 years. See the age? 4 months. So baby, see he is struggling. When doing the X-ray, the baby is struggling. So it is not possible to do the ideal X-ray. But what obvious finding do you expect? You have to take. This is the X-ray of the chest. Patient there may be kinking. If you can say, if you not say, you will not deduct any marks for that. But if it is obvious, you can make any remarks. Any soft tissue, any obvious changes in the lung field. What is the angle? This is actually an expiratory film. You need not to tell these things, but this is an expiratory film because child is crying. Luckily, if you are on inspiration, then you get inspiratory film. So it is possible all the things. I did. There is some opacity in the perihylar regions and the opacity in the right lower region and mild patchy opacity. This is not a classical X-ray for the exam purposes. I remember in every X-ray, this portion is very prominent. This is due to right lower pulmonary vein. If you see, this portion is a linear X. Opacity is due to, that is due to. This is not a standard X-ray. Diagnosis? See, this is an X. So here again you see right, left. Never forget the basic things. Right, left indicated by the right. Apex width not seen. That point will comes out. Fundic gas is also not seen. No other data. All together you make a decision which is right, left. But this is a very good pointer. Right, left. This is number one. So here again come from the outside. Soft tissue no obvious bony changes. Then come to the lung. Both the lung is okay, but here the lower lung is not visible. Only the upper portion of the lung is visible, and the cardiac salute can change. Cardiac salute can change totally. The big heart. So big heart. So from this picture, it is very obvious. And that will carry a negative marks. Do not do that. So this is cardiac salute have been changed, and there are two things happen. The heart shape get changes, or cardiac salute is okay, but it is advanced. Means cardiac thoracic ratio have been changes. So today's task is do, you can write down number one, how to assess the cardiac thoracic ratio, CT ratio. Number two,